All right, everyone. Welcome to THETA round. You ready? So there are people on the webinar?
4 people.
Okay, so 4 more people on the webinar. So it's my pleasure to introduce Kelly Barrett to our rounds today. Kelly is a critical care physician at UHN at the Toronto Western Hospital. She's got a master's degree in health policy, planning and financing from the London School of Economics and London School of Hygiene and Tropical Medicine. It's a joint degree. And so she does work clinical practice, as I said, at the Toronto Western, but she's also doing a lot of research. And so she's a health services researcher. Her interest is on value-based delivery of critical care and also how we organize critical care in Ontario. So welcome, Kelly. And so you know who's in the room. We will go around and give a brief introduction. So I always can start because I'm introducing everyone. So I'm Viana Sender. I'm a scientist here at THETA and associate professor at IHPME. Oh, no. Okay, let's start here. Okay, you get a break.
Hi, I'm Donna Stewart from Department of Psychiatry.
Yeah.
I'm Narahari Timothy, a PhD student at IHPME.
I'm Phyllis Bilia. I'm a cardiologist with an interest in heart failure and apparently the director of the mechanical support program here on the medical side.
I'm Lauren LaPointe-Shaw. I'm a general internist, friend of Callie's, and health services researcher.
Neil Ferguson, I'm head of critical care here at UHN and in Clinipi and IHPME.
Eddie Van, I'm also an intensivist here with an interest in ECMO.
I'm Margaret Herridge, an intensivist here, senior scientist, and interested in ICU outcomes.
I'm Rafael, I'm a postdoc fellow here.
Suzanne Chung, I'm an RA here at THETA Collaborative.
Frank Cron, I'm a general internist here and director of THETA.
Well, I'm scientist with Ted Rogers and Peter Monk, and I'm associate director of THETA.
I'm Jason Wong, research associate.
I'm Cheng Wei, PhD student here at THETA.
Troy Francis, RA at THETA.
Okay, thanks everyone. Kelly, I don't know you want to have questions in between or you want them all at the end?
One more person that has to.
Oh, yes.
Okay. Joanna Biletsky, I'm a research librarian here at THETA and the moderator for online participants.
All right, so.
Okay, and I think if there are questions that come up during the presentation, just go ahead and interrupt me. It's totally fine. So thank you and welcome. I'm Callie Barrett, as Beata said. I'm an intensivist here, and I also have a research interest in value-based critical care, cost effectiveness, and sort of health system delivery from a value-based perspective. And I recognize that my audience is sort of split critical care, HTA, so I'm hoping that my talk will sort of bridge the gap for everyone. Briefly going to give a primer on critical care in the Canadian health system, review some work that I've done, a case study looking at the evidence for cost effectiveness for VV ECMO in ARDS, discuss this case in the context of other life-saving interventions and the associated opportunity costs to the health system, and discuss how this concept can provide a different perspective when we look at really challenging scenarios that we face in critical care. I have no conflicts of interest to disclose, and we'll get started. So briefly, what is critical care or the intensive care, and the terms are used interchangeably. Really, we look after the sickest patients in the health system. We use a lot of intensive monitoring of vital signs, of lab work, of the patient's clinical condition. We use lots of tools to help us with that monitoring, various arterial lines, central lines, PA catheters, ICP monitors, etc. We can administer very specialized medications that can't be administered elsewhere in the hospital. We can provide organ support, and that's kind of what we're known for. So ventilation for respiratory failure, renal replacement therapy for kidney failure. We can administer high flow oxygen. We can use balloon pumps or ECMO or VADs for circulatory support. And one of the features of our unit is the really low nurse to patient ratio. So often our nurses have a single patient that they're responsible for, occasionally 2 patients, but really very close monitoring of the patients by nurses 24 hours a day is one of the hallmarks of the intensive care unit. And it's a very complex, dynamic, and large interprofessional team that looks after our patients, physicians, nurses, respiratory therapists, pharmacists, dietitians, OT, PT, social work. And really our rounds are a very large group of people looking at that patient from various perspectives to come up with the best decision for the day. And these images are all from the web. And this is when, I think it was the Globe, was at Sunnybrook doing a piece on their critical care unit. And this is actually a small group of people around the patient at daily rounds. The ECMO rounds here at TGH, there can be 15, 20 people at the bedside. And an example of some of the monitors is actually pretty low acuity monitoring for us. Continuous ECG monitoring, ART lines, PDP, ICP, continuous oxygenation. So we're getting a lot of data points collected that we then have to synthesize, including lab values and clinical condition, to come up with decisions and treatment plans for our patients to help get them through their critical illness. So you can imagine with the complexity of all of these interventions and these sick patients that this is a pretty expensive place for the hospital. In 2016, CIHI put out this really interesting report, Care in Canadian ICUs, and one of the things that they highlight is that there is an increase in the severity of illness among hospitalized patients, and that this coupled with Canada's aging population, this really can be expected to contribute to a rise in the use of and the cost of ICU in the coming decades. And one of the things that we see is that as a proportion of overall patients admitted to hospital, more of them are using the intensive care unit. So from 2008 to 2014, there was a 7% increase in overall hospitalizations, but 12% increase in admissions to the intensive care unit. So the patients being admitted to hospital are sicker and more of them are needing to come to the critical care unit. Another way of looking at this is sort of the acuity of illness. And this is a chart also from that report that stratifies patients based on whether or not they received mechanical ventilation at all, or for a short or long period of time. And when you look at 2007 to 2014, among the bottom row, which was no ventilation, there was a rise of approximately 2,000 people admitted to the ICU. In terms of patients who required long-term ventilation, around 2,000 more patients between those two time periods. But then when you look at the short-term invasive ventilation group, there were 10,000 more admissions in this group, which really shows that the types of patients driving this increase in utilization are these patients requiring mechanical ventilation. These are sick patients. They have either respiratory failure or infection. They may also be surgical patients who are having very complex procedures performed with a large number of medical comorbidities, which requires them to have monitoring in an intensive care unit post-op, and they come to us directly from the OR intubated. And so it isn't the low acuity patients driving up the increased utilization and demand in the critical care unit. It's very sick patients who really do deserve to be there. It costs more to be in the intensive care unit than it does to be elsewhere in the hospital. And this is pretty intuitive based on what I've already told you about the number of people involved, the technology that we use, the monitoring. And generally speaking, regardless if you're in a small community setting or a large urban academic center, it costs 3 times as much per day in the ICU compared to the general ward. And this is somewhat concerning when we consider the fact that as a share of GDP, our spending on healthcare has basically been in a straight line upwards since the 1970s. And in 2012, the Commission on Reform of Ontario's Public Services was released by Don Drummond, and when he looked at healthcare, he highlighted this trend, that Ontario's public health costs in the absence of significant reform would grow by 6.5% annually over the next 2 decades. And what's really alarming is that this rate of growth is exceeding the growth of our nominal GDP, reflecting what I just showed you, that our spending on healthcare is eating up more of our overall revenue year to year, and that clearly the status quo is not sustainable. The alternative, or the fix to this, is not simply raising taxes. That's not socially acceptable. There comes a point where there's a maximum threshold for taxation. And so he proposed multiple system reforms to try to address this, to ensure the sustainability of our health system. Well, system reform is very challenging. And in the meantime, while we're waiting for that system reform to take place, which hasn't yet happened, we are on a day-to-day basis met with this real dilemma of increasing population demands for incredibly expensive critical care resources, while at the same time facing increasing budget constraints. And how do we sort of reconcile this dilemma that we're faced on a daily basis? And I believe that as clinicians, and I wear my clinician hat, that we really have to think about using our finite critical care and health system resources responsibly. We need to be somewhat a driver of this restraint in our spending. How do we reduce costs in the critical care unit? Well, 85% of our costs are actually fixed. There's not much we can do about them. They're based on the number of beds in the system, the nurses that we hire to staff those beds. And when we look at the number of beds in Ontario and Canada compared to around the world or within Canada in Ontario, we actually are somewhat in the middle. We're not an outlier. So the graph on the left shows our hospital beds per 100,000 charted against ICU beds per 100,000. You can see that Canada, which is the orange dot, is somewhat on the lean side in terms of overall number of hospital beds per 100,000, and somewhere in the middle for intensive care unit beds. And then on the right, you can see that there's pretty significant regional variation in terms of ICU beds per population. But again, Ontario is somewhat in the middle when it comes to ICU beds per 100,000. We also know that the majority of ICU beds exist in urban and academic centers, and many of these urban and academic centers are operating at about 90% capacity. It is not uncommon for us to arrive to work in the morning and have patients in the emerge waiting for a bed in the ICU, or patients in PACU. Overcapacity, overcrowding is something that we deal with on a regular basis. And so really in the large urban academic centers, ICU capacity is pretty well utilized. There's not a lot of room for cuts here. This is not the solution to our budget problems in ICU. So then there's the approach of, well, let's look for the low-hanging fruit and try to weed out the things that are really not very cost-effective. And Choosing Wisely campaign, which is gaining a lot of traction across medicine. We have a Choosing Wisely for critical care, and it includes things like not ordering diagnostic tests unnecessarily, not transfusing red blood cells unnecessarily, not using TPN, not deeply sedating or mechanically ventilated patients unless there's a specific indication, and doing a daily sedation and lightening. And then also not continuing life support in those patients for whom ongoing aggressive life-sustaining therapies is not going to confer a benefit. That's easier said than done. But really, this whole campaign is looking at eliminating practices that have little clinical benefit or are incredibly costly to the system. So on a day-to-day basis, as clinicians, we need to be choosing interventions with the best value. So how do we do this? How do we make this decision that this is a good intervention, or this intervention has value? Well, we need to look at the ones that have the best, most health gains for a given expenditure of health system resources. And in order to identify those, we can look at economic evaluations. And this side of the room is very well versed in that type of research. They explore the health benefits from a specific output of resources or dollars. And there's different types of ways we can analyze this data. We can do a cost effectiveness analysis, which looks at a specific health benefit gained from a health intervention, often expressed in cost per life year saved. The cost utility analysis, which looks at quality adjusted life years gained from a specific resource expenditure, and cost benefit analysis, which are sort of the financial cost savings from immediate investment in health systems. And cost utility analyses are often preferred because they express the output in cost per quality. And the quality adjusted life year is a nice sort of metric because it allows us to compare health benefits between various interventions. So we can compare the value of an intervention in a surgical program and compare it to the value in an intervention in a public health intervention, and figure out what the cost per quality is and determine which one is more cost effective if we were deciding between those two programs. But then also within a specific disease state, we can compare two different interventions and see which one provides us the most health benefit compared to the other per health expenditure. So I looked at an example of this cost effectiveness analysis within critical care, and I did an economic evaluation of veno-venous ECMO for acute respiratory distress syndrome. And I'll just briefly describe what acute respiratory distress syndrome is. So it's essentially catastrophic hypoxemic respiratory failure. The patient cannot get oxygen into their bloodstream. That's acute in onset, characterized by a pretty crappy looking chest x-ray like the one you see here with bilateral opacities. That's not because of heart failure or volume overload. And when they're on 5 centimeters of PEEP or CPAP, there is derangement in their PF ratio, which is a fraction of how much oxygen is in the blood compared to the oxygen that we're delivering. It can be caused by many different things. Infection, trauma, inhalation, burns. This is not an exhaustive list here, but the pathology behind it is the alveoli in the lungs, the cells that line the alveoli become weak, allow the migration of inflammatory cytokines, proteins, and fluid into the alveoli, and really prevent the lungs from being involved in gas exchange. It unfortunately has a very high mortality rate of about 35 to 40%. We see it relatively frequently. About 10% of patients admitted to the ICU are diagnosed with ARDS, and we don't really have a silver bullet drug to treat it. Primarily, it's supportive care with mechanical ventilation to try to improve the oxygenation, and then also at the same time providing that mechanical ventilation in a way that doesn't then further induce lung injury through ventilator-induced lung injury. We do have some rescue therapies which may have some evidence-prone positioning, actually flipping the patient over and ventilating them while they're lying on their belly can help sometimes. And then we have these other rescue therapies that we sometimes rush to when the patient continues to deteriorate, including ECMO and sometimes HFO, although the evidence is less convincing for that now. So I want to talk about venous ECMO as a rescue therapy. So for those of you who don't know what it is, this is a beautiful illustration from a New England Journal paper. Essentially, it's lung bypass that we perform in the intensive care unit. And so there's 2 different ways that we can access the bloodstream. We can either put a cannula in the femoral vein and the IJ, or we can have one cannula in the neck that just goes into the IVC. And essentially, venous blood that is deoxygenated is sucked out of the body. It goes through a pump. The pump then pushes it to an oxygenator, where there's sort of like a dialysis membrane across which gas is flowing, oxygen goes into the blood, carbon dioxide comes out, and then the oxygenated blood is returned to the body in the venous side. So it's called venous ECMO because the blood is returning and entering the body, leaving and entering the body through the venous system. Veno-arterial ECMO, VA ECMO, you also sometimes hear about, that's where blood exits on the venous side and returns on the arterial side. And in those situations, the pump is also then taking over from the heart to actually perfuse the body and pump blood through the body. We're not talking about that here. We're specifically talking about VV ECMO. VA ECMO was not felt to be a appropriate treatment for ARDS. So is there evidence to support the use of VV ECMO for ARDS? Eddie Fan here has worked on this project. He did a systematic review with Lavina Munchie and a few others looking at what is the evidence out there for VV ECMO for ARDS. And there are 3 papers that they identified that were specifically looking at VV ECMO in patients with severe ARDS. The first one, that PEC 2009, that's the CSER trial. So that is a randomized control trial that was performed in the United Kingdom, where they randomized patients to either referral to an ECMO center where they may or may not have received ECMO, or just usual care at their home hospital. And then the other 2, NOAA and SAM, those are 2 observational cohort studies from the H1N1 flu pandemic. In both of these, in all 3 of these studies, the average age of the patients enrolled was about 39 to 45, so they were pretty young. And the outcome, when you look at the pooled analysis, is it looks like there may be a mortality benefit associated with VV ECMO. So it's pretty compelling and it's pretty sexy. So there's a lot of excitement about VV ECMO in this patient population. It's certainly compelling as a clinician when you're at the bedside. The minute you put them on the pump, they're cannulated, their stats immediately improve unless something's really going wrong, it certainly makes you breathe a little bit better to see the stats at 96%. And also it allows for lung rest, which we think is beneficial in that by dialing down the ventilator settings, we are then reducing the risk of ventilator-induced lung injury. And as we saw earlier, it may confer a survival benefit. However, it's incredibly resource-intensive and expensive. The technology itself is expensive. The disposables are expensive. The staffing requirements are high. It needs for sure getting a one-to-one nurse to patient, and then it also often involves a perfusionist on the bed, at the bedside 24 hours a day. These are expensive, well-trained, highly skilled people to be at the bedside, both of them 24 hours a day. Many of these patients on ECMO require heparin, and so there are risks of hemorrhagic complications. You can imagine if you have your body's blood flow going through an external pump, that if something went wrong with the circuit, that could be quite catastrophic. There's also risks of infection because you have two large catheters going directly into the central blood. And these require technical expertise. You don't want the ICU team out in the periphery that has a 5-bed ICU that only ventilates 3 patients a year, putting a patient on ECMO. This really needs to be done at an expert center that has a large volume. And there's lots of unknowns. We don't know what the optimal ventilation strategy is for these patients. We don't know really how we should be anticoagulating them. We don't know what the long-term outcomes really are in terms of their quality of life. Nor do we really know if it improves hospital length of stay. So despite all these unknowns and the reasonably compelling evidence that perhaps ECMO is effective, I will ask the question, is VV ECMO cost effective when it's compared to mechanical ventilation for severe ARDS? So I conducted a cost utility study, so I looked at cost per quality of VV ECMO for ARDS. I performed a cohort state transition model where I ran the model for patients who received mechanical ventilation and for those receiving VV ECMO. My cohort was age 45 because that was relatively similar to the ages of the patients in the data that I had to inform my model. I had a cycle life of a year because that was the interval that I had data for long-term follow-up data. I chose a health system perspective. I used a lifetime time horizon. My effectiveness data was from the systematic review. That was for mortality, survival from ARDS. And then ongoing mortality from Canadian life tables. I used utility data for each of the cycles from published utility data. I had to make some assumptions, and then Canadian population norms. My costs were from the PEC randomized control trial, and then some of Margaret Heritage's long-term ARDS follow-up data on healthcare utilization. And then I mapped that onto long-term population healthcare utilization from Ontario. I applied a discount rate of 3%, and all the costs in this most recent iteration are converted to 2015 US dollars. And I performed many sensitivity analyses. I looked at different effectiveness data from an alternative systematic review that found the same 3 studies that Eddie's did, but just pooled the patients and a little bit differently, did some different statistical analyses to see if different effectiveness data significantly changed the results. I looked at some different confidence interval ranges. I did a 5- and a 10-year time horizon analysis to see what the difference is if we just stop running the model at specific points in time, and I applied some different discount rates. So in the figure there shows the figure of the model. It's actually a very simple model. The patients entered in ARDS. They either survived their ARDS based on whether or not VV ECMO or mechanical ventilation was effective. They accrued costs and utility values for time in that cycle. And then if they died, that was it. They didn't contribute anything more to the model. But if they survived, they then went into this recovered state where based on how many years out they were from their time in the ICU, they had specific utility values and costs. And whether or not they moved on to the death state was based on their life expectancy from Canadian population life tables. And when you run one of these models, you generate a curve that looks like this. And what this, the x-axis is the cycles, the y-axis is the proportion alive. And you can see that as we would expect, given what I told you about my model, that the big difference in survival is from whether or not ECMO works compared to mechanical ventilation. But then imagine that as the time goes on in this cycle, the people in the model that are alive are continuing to accrue costs and they're continuing to accrue qualities. And you sum up the area under the curve for the 2 different cohorts, and that's how you can calculate the total costs and total qualities associated with the 2 different interventions. So VV ECMO, the total cost for the cohort that ran through my model was $219,000 compared to $100,000 for VV ECMO. I'm sorry, for lung protective ventilation. It's an incremental difference of around $110,000. There is an incremental gain of 3.15 qualities and an incremental gain of 4 life years. And this incremental cost effectiveness ratio is how we describe these results, and it's the incremental cost divided by the incremental QALY, and that gives you 35,472 cost per QALY, or that's the cost per QALY associated with ECMO compared to lung protective ventilation. I also did some sensitivity analysis. This is a tornado diagram. So imagine that vertical line in the middle represents 35,000 because that was my ICER from my base case analysis. The x-axis is from 20 to 60,000, representing other ICERs. And each of these horizontal bars represents where, if I change one of my variables, where does the ICER then lie? So you can see at the very bottom, mortality of ECMO defined by the low and the high confidence intervals from the Munchie systematic review. So you can see that when we use the low confidence interval from the mortality associated with ECMO, the ICER starts to get up to $58,000. And similarly, the one that's second from the bottom, the same thing, that's from one of the other analyses from that other systematic review. And the take home from this is the ICER changes when the effectiveness of ECMO changes. So the results of my study are actually sensitive to the effectiveness of ECMO. So if the truth is not what I have assumed it to be, then my ICER is not necessarily the true reality. I think this is possibly the most important take-home message from my study. When I looked at a 5 and a 10-year time horizon, and this is the cost per QALY if I stop the model at 5 years and I stop the model at 10 years after. At 5 years, the cost per QALY is $165,000 per QALY, and at 10 years, it's $85,230 per QALY. And if we go back to my model, you can understand how that's the case. That the proportion of people alive later in the model is where they're accruing the additional QALYs. When they're initially unwell and critically ill, their utility values are quite low. We know that our ARDS survivors actually have a really poor quality of life, and it takes them a long time to get back to baseline, if ever baseline. And so they need their life expectancy years in order to generate additional QALYs to make up for the initial investment. We plot incremental cost effectiveness ratios on this cost effectiveness plane, and the middle point is 0, and everything to the right is the new treatment is more effective, and everything to the left is the old treatment is more effective. Everything to the top is the new treatment is more costly, and everything to the bottom is the new treatment is less costly. So based on which quadrant of this graph you're in, you can determine whether or not a new treatment is either a slam dunk win, like in the bottom right, it's more effective and less costly, or a slam dunk reject, less effective, more costly. It's the upper right quadrant of this plane that's where the most sort of challenge from a policy decision comes from, where it's both more effective but also more costly. The dashed line represents our willingness to pay threshold, and that represents where on that graph we are willing to invest a certain amount of money to gain an additional QALY. If the ICER falls below that dashed line, then we would say that the intervention is within an acceptable willingness to pay threshold, and if it's above it, we would say it exceeds our willingness to pay threshold. I ran a Monte Carlo simulation, and my probabilistic sensitivity analysis plotted on that plane looks like this. So essentially, I'm only showing you the right half of that plane. You can see $0 there is the horizontal line. Vertical is cost, and the x-axis is QALYs, additional QALYs gained. You can see, and the way this analysis is run is there are 10,000 simulations run. Every simulation is drawing a value for a parameter in the model from randomly from anywhere in the possible ranges of values. So if the parameter is normally distributed, you take the 95% confidence intervals, and somewhere between those 95% confidence intervals, it pulls a value, plugs it in, and it does that for every single value that can be plugged into the model, and then runs it. So you can see that there are some outputs from the model where the ICER was quite high, up by $1.6 million, and that would be, clearly there were some bad outcomes and high costs in that simulation. And similarly, there were some outputs from the model that showed that it was actually more effective and less costly. The cluster sort of centers around, you can see just under $50,000. It's somewhere, the mean from this analysis was 32,115, and many would argue that this is actually the result of my analysis. This is the analysis that takes into account the uncertainty in all of my variables that I put into my model, and that this is actually the ICER that probably reflects our uncertainty. So the other way that we can look at this is we can plot the various ICERs on the willingness to pay threshold. And essentially what this is doing is taking all the ICERs from this graph and then plotting them one versus the other based on our willingness to pay threshold. It reflects the uncertainty in our results based on how much we're willing to pay. And the take-home message from this graph is that at $22,000, a willingness to pay threshold of $22,000, VV ECMO is 50% likely cost-effective. So the conclusions that I've drawn from this work is that based on what we have currently, VV ECMO is likely cost-effective for young patients at a reasonably accepted willingness to pay threshold. The qualities gained over the survivor's lifetime are what drive the ICER into the acceptable range. And this is a really important point for us to think about from a clinical perspective. This does not inform on the cost effectiveness for use in older or frailer patients. And Margaret is sitting in the audience. She could talk for hours about the understanding that we have. Oh, you could eloquently talk for hours. The understandings we have now that our ICU ARDS survivors leave the ICU significantly, with a significantly diminished quality of life, functional capacity, mental capacity. They're broken, so to speak, and they require a lot of rehab and help to get better. And the older patients don't do as well. And the frailer patients, even the young, frail patients, don't do as well. They are more likely to die. They're more likely to stay in hospital and never go home. And they're more likely to have a diminished quality of life when they get out of the ICU. So this does not inform on those patients. This really only informs on healthy people with zero comorbidities who are young, who have a really good life expectancy otherwise. The other important take-home message is that the results are sensitive to the effectiveness data. So we need more data on ECMO, and if VV ECMO proves to be less effective than I input into my model with these results, then this needs to be revisited because it may still be statistically significantly better than mechanical ventilation, but if it may actually then fall into a much less cost-effective range. And so really we feel it should be limited to expert centers. It should really only be offered on a case-by-case basis. And really, it shouldn't be offered to patients with a really small chance of a meaningful recovery. How does this compare to the CSER trial? They did a cost-utility analysis. And pleasantly enough, their results kind of mirror what I had. So they followed QALYs. They followed their patients for 6 months and had a QALY utility value at 6 months. And when they stopped and did their analysis at 6 months, the incremental cost effectiveness ratio is 1.6 million pounds per QALY. When they used costs based on NHS tariffs instead of the actual cost that they calculated in their trial, it's $732,000 per QALY. But then when they did a very similar probabilistic sensitivity analysis and they did some modeling and they discount their costs and outcomes at 3.5%, their incremental cost effectiveness ratio conveniently falls under 20,000 pounds per QALY. And the results that their conclusive statement is VV ECMO or ECMO is cost effective for ARDS. That is actually what they state in their paper. So how does this compare to other critical care interventions? I'd love to be able to tell you that we have a whole lot of economic evaluations in critical care and that there's a lot of really recent data. There's not. In 2003, so this is a really old paper, Danny Talmor did a systematic review of the cost-effectiveness literature and really only found 19 published CEAs. Many of them were various scenarios. I think they were trying to explore, I have to admit I have not read these primary papers, exploring, I think, futility amongst mechanical ventilation in patients with sepsis, generating various incremental cost-effectiveness ratios that range from ones that are generally acceptable to ones that wouldn't be. And then there is a whole slew of them looking at activated protein C, which we don't even use anymore because it was found to be harmful, but was a very, very, very expensive medication. And there was a lot of concern that was potentially not cost effective. So that explains all of this sort of activity in this field. But it's completely irrelevant now because we don't use it. So what about other potentially life-saving interventions? So I was sort of noodling on LVAD, stem cell transplants, lung transplants. I was thinking about what other interventions similarly do we use to rescue people from essentially imminent death, and that are widely accepted. So what are the ICER for the things we're already doing? So conveniently, OTAC assessed continuous flow LVADs, or left ventricular assist devices, for destination therapy in patients with heart failure. I was not on OTAC when they reviewed this, so this is just purely what I've read from what's available on the web. And they did not perform an economic evaluation themselves, but they did identify 3 cost-effectiveness analyses that were published in the literature looking at continuous flow LVAD for destination therapy. Really, really high ICERs. You can see that in that top, the long paper, $201,000 per quality. The middle paper, 107,000 euros, and on the bottom, $198,000 per quality. What did they do? They recommended fund it. Why? Because there was a survival benefit with these patients. These are heart failure patients for whom transplant is not an option, who have a life expectancy that's in the single-digit years, and this conferred a statistically significant survival benefit. So they recommend that it be publicly funded. They recommend that it only happens at expert centers, but they put this sort of rider on it that the Cardiac Care Network or Trillium Gifts of Life have to be continually collecting quality of life and survival data, and OTAC is going to review the findings in 2 years and perhaps update this decision. And in their decision determinants framework document, OTAC said their LVAD is a relatively expensive intervention, and the incremental cost effectiveness associated with continuous flow LVAD for destination therapy is relatively high, not cost effective within the traditional cost effectiveness threshold of $50,000 to $100,000. What about stem cell transplant? I had a hard time finding good data on this one. So this is a quick and dirty search that found me a systematic review of some economic evaluations for stem cell transplants in various populations. They were looking at both peripheral blood collected stem cells, bone marrow collected stem cells, and banked unrelated cord blood stem cells in both pediatric and adult patients. I was kind of surprised that the ICERs were not as high as I was expecting them to be. Some of these ICERs are, the one at the top, that's in the pediatric patient, so I don't know how to interpret that, but 687,000 per quality, 1.69 million per quality. I think there's something else going on there in the pediatric world. The ICER for the base case, the next one down, that's Canadian data at a single center. It's probably Toronto, 52 patients, only $18,000 for their base case analysis. So not as expensive as I would have thought. What about lung transplants? I found a Quebec paper that calculated, they performed an economic evaluation, they did a model, they used Canadian data, and their ICER was 46,631 per quality for a lung transplant. UK data, single lung, 50,000 per quality, double lung, 45,000 per quality, heart lung, 41,000 per quality. So these are relatively cost-effective interventions that happen all the time. So when we look at these results, VV-ECMO really appears to be within that range of what we consider to be an acceptable cost-effectiveness. And the ICER is less than $50,000. But let's talk about that $50,000 willingness to pay threshold. It's often quoted as the benchmark. and it's actually falsely believed to have stemmed from the U.S. government's decision to fund dialysis for patients with end-stage renal disease who were on Medicaid. The ICER for IHD was actually closer to $20,000 to $30,000 per quality in that analysis, and Medicaid was already covering more less cost-effective therapies. So there was no 50,000 threshold involved in that treatment decision. And it appears that actually this dogma of sort of 50,000 being the threshold stemmed from several very influential cost-effectiveness analyses published in the 90s that used a threshold of between 20 to 100 and sort of used 50 as a nice middle-of-the-road benchmark. Interestingly, the World Health Organization, as they're trying to assist health services in nations all over the world, including in low and middle income countries where they don't have the same resources that we have in very more developed nations, recommend that the willingness to pay threshold should be closer to 2 to 3 times per capita GDP. In Canada, our per capita GDP, according to Google yesterday, is $47,000 per person. So that would roughly equate to about $120,000 per quality. And it's true that generally speaking now, $100,000 to $150,000 is actually more often quoted. I also think it's important to note the United States has actually legislated against an explicit threshold. They are not allowed to use a threshold in their analyses and their decisions to fund treatment. And then we look at the UK. NICE actually has an explicit threshold of 20 to 30,000 pounds per quality. Anything that falls under that is approved. And anything sort of 20 to 30 is considered. And one of the articles I read actually said that there's a bit of an ICER creep and that actually willingness to pay threshold is actually closer to 40,000 pounds per quality. And then in response to some pretty aggressive media action in the late 2000s with some patients who were denied access to potentially life-saving or life-prolonging cancer medications, the Cancer Drug Fund was established, which was a pot of money that was set aside for patients to access really expensive new cancer drugs. The threshold that they allowed to be for these assessments was 50,000 pounds per quality, and there were some exceptions. The patient had to have a life expectancy of less than 2 years, and the drug had to have been proven to extend that life expectancy by 3 months. And then I didn't put it here, but also there had to be a limited number of people in the population with that condition. They were trying to avoid 1 million people showing up requesting this drug. So what about the budget impact of these decisions? Every time OTAC makes a recommendation to the Ministry of Health or NICE makes a recommendation to the government and to continue to fund, or like Lauren was talking about the CAR T cell therapy, when we approve these technologies or these drugs or these machines or procedures, that money to fund that service is coming from somewhere else. There isn't a limitless pot of money that just keeps growing. It's a finite amount of money, and it's our tax dollars. And when we allocate it to one area, we have to take it away from somewhere else. So we're either cutting other services in healthcare, we are closing beds, we're firing nurses, we are cutting OHIP billings, we are maybe not building that road, maybe not building that school, maybe not paying our teachers as much. There are unintended consequences and knock-on effects to society that reflect these decisions that we're making. And there's Carl Claxton and a group of people at the University of York who, I did a course there, these people are brilliant. They responded to a call to actually look at ways of estimating from an actual quantitative perspective what thresholds should be based on the overall budget of the health system and based on the actual spending that the health system was doing to keep people healthy. And through a very complicated analysis based on population, health utilization, and NHS costing data, they were able to estimate that it generally costs the NHS 13,000 pounds to achieve one quality of health. And therefore, any decision to fund a service with an ICER that is above 13,000 pounds is actually going to cause health deficits to someone in the NHS. And they then graphed this out and showed, so for every $10 million that the NHS decides to fund, if the threshold, the willingness to pay threshold is 20,000 pounds per quality, This new intervention is going to get 500 QALYs. But because of what we know how much it costs to buy a QALY in the NHS, that's going to then have a net loss to other people, resulting in a loss of 773 QALYs. So a net harm to the NHS of 273. And when we go up to the £50,000 per QALY, we're gaining 200 QALYs. We're still losing that 773 QALYs. A net harm to NHS patients of 573 QALYs. This is very concerning. Then what about their cancer drug fund? Well, it's even more concerning. They actually took the raw number that was allocated to that fund annually, and most recently, 2015, 2016, 340 million pounds, a loss of 26,000 QALYs elsewhere, a net harm to the NHS of minus 21,000 QALYs. Then, because they were able to actually calculate where in the NHS and amongst which patients are these losses going to occur, and I think really importantly, significant loss amongst the mental health sector. It's the mental health sector is where a lot of the losses took place. And there were life years lost in cancer and circulation and amongst respiratory patients and GI, but there were 95 QALYs lost amongst patients with mental health diagnoses. So one of the really nice things about this analysis was it actually kind of puts a face on the opportunity cost of these investments. And they actually have an Excel file that you can go into and you can plug in various things and you can look at if you were in a specific primary care trust, how will it actually affect you in your primary care trust. It's a very powerful tool. But being able to actually see what the knock-on effects of an investment in a service elsewhere is quite interesting and, quite frankly, kind of alarming. So why are these decisions so hard? And the first one is it's the rule of rescue, right? As if we see someone dying on the street, we're all going to run and try to help them, or we should. And it's a human sort of moral reaction to try to save people from immediate peril, regardless of the cost. The tension is that what is best for society overall may not necessarily be what's best for the individual. And policymakers have the really difficult task of trying to make decisions based on what's best for the population. As physicians, we're taught that we have to do what's best for the patients in front of us, but then we're also told we have to be stewards of our health system and be conscious of the resources. So the way I approach this dilemma is that I believe as physicians, for the physicians in the room, that we really do need to consider both the interest of the patient in front of us, but also the patient, the next patient who's going to come to us needing care, and the patient behind us already receiving care in the health system. And we have to be conscious of the fact that our clinical decisions have small but cumulative effects to the sustainability of our health system. And we really do need to consider the cost and the value of the interventions that we're proposing when we're making clinical decisions. Yes, this happens at a meta level policy-wide, but actually at the bedside, I think these kinds of decisions can come into our mind. I think one very interesting way to think about this issue that might help us a little bit sort of navigate these challenging scenarios is when critical care no longer provides a meaningful benefit. And these are incredibly challenging cases for us, where if a patient is on life support and is, we feel, not going to recover, we can be compelled because of various legal reasons now to continue to provide that care. These cases, probably from an economic perspective, are the least cost-effective use of critical care resources. Patients in unconscious states are often assessed a negative utility value or assumed to have a utility value that's actually worse than death, a state worse than death. We don't believe that they'll have any quality gains to offset the costs. But the ethical and the issue, the problem here is the alternative is their death. And there is a very complex interplay of ethics, religious beliefs, and law. And the medical legal issues certainly make this a little bit harder for us to actually act on what we know to be medically indicated. The Rizzulli decision essentially made it the law that withdrawing life support is a treatment and requires the patient or their patient substitute decision makers' consent. And then this is played out into our College of Physician and Surgeons of Ontario practice or clinical practice guidelines, or what do we call them? They're just the policies in terms of how as physicians we must behave. So if we cannot make a unilateral decision to withdraw life-sustaining treatment, we have to have the buy-in from the family, and we don't always get it. So if there's disagreement, yes, we can go to the consent capacity board, but these cases are always very complicated. They take a very long time. They're incredibly ethically fraught, and they're challenging for all involved. And I really do think, though, that when we're handling these situations, we really do need to have that little voice in the back of our head telling us that there is an opportunity cost associated with this. And I know that it was brought up when they were at the Supreme Court. The opportunity cost was discussed. It was brought up by the physicians involved, but unfortunately, the judges did not really respond to that. It certainly reinforces the notion that we have to have discussions with our patients prior to clinical deterioration, but that's always easier said than done. So the big picture looking back now is, as clinicians, I think we really do need to be considering the value of the interventions that we offer. We have to remember that our clinical decisions have knock-on effects in other places in the health system and society at large. We need to keep the issue of treatment value and the opportunity cost in mind. And I think that one of the ways that we can use these types of economic analyses is to actually help us identify the right patients for the intervention. So my VV ECMO for ARDS analysis, I think one of the take-homes that I get from it from a clinical application is VV ECMO is probably not the right intervention for a very frail patient or a very old patient or a very, very sick patient who's really unlikely to survive their illness. Those are not the patients in whom we need to be investing these kinds of resources because they're unlikely to get enough benefit out of it to make it a cost-effective intervention. And investing resources in low-value critical care may be harming the most vulnerable people in our society. And we do not know if these decisions are in line with societal values. We don't have enough evidence to make these decisions. We haven't asked society in Ontario if this is how we want to be allocating our resources. But that data I showed was UK data, but our health systems are not incredibly different. I would imagine that it's probably the same types of people who are being disinvested in our health system as a result of these investments in aggressive end-of-life care. The big take-home is that we do need to be collecting, analyzing the data that helps inform these economic evaluations, because only with this information are we able to assist evidence-based decision-making at the policy level, and then in turn, and at the same time, help clinicians most efficiently allocate scarce resources at the bedside. So in summary, we've talked a little bit about what critical care medicine is. We've talked about the economic pressures that it faces. We looked at my case study of VV ECMO for ARDS. We reviewed some of the evidence for other life-saving interventions, and we explored the issue of opportunity cost and the willingness to pay threshold, and where this is really concerning, I think, in critical care. And I've highlighted that this is a really important area for further research. Thank you.
I have one comment and two questions. So in your background, I think you put how healthcare cost is increasing. Probably that's very much true with the population size increasing, dollar value is changed over time. But interesting to look at often we don't use how the outcome would change from over a year. If 1990s, our outcome of the treatment was low and it improved over time, over years, like treatment outcomes, their quality, all of those. Probably that justifies the increasing healthcare costs. It's not costing, but it's benefiting the overall society. That's one comment. And the question in your studies, I was curious on the utilities values used in that studies. Could you comment how, because you showed in the systematic review there is very few studies. I was curious the utilities values used in your studies, how incredible or how qualitative those data are?
So the utility values were from a published study of ECMO patients who had ARDS during the H1N1 flu pandemic from Australia and New Zealand for 6 and 12 months after their intensive care unit stay. So they informed the first state. Then I used that as the 12-month baseline. Then I had Margaret Heritage's work on our quality of life sort of trajectory. So then I mapped essentially the rate of increase from her work onto the utility values for the population norms. And I had to make an assumption because I didn't have the data that it would increase at the rate that the patients in Margaret's study improved to a population norm at, I think it was 5 years, I think.
Now, my final question. You look at the 5-year and 10-year. Is there a particular region, or what would be different if you use the life horizon?
So my base case was the lifetime horizon. So 35,000 was the lifetime.
Okay.
Great presentation, thank you. So question for you, you did this case study, it's very interesting, so what? If anything came up, like did did you present to OTAC, did you like?
So OTAC has previously done a brief review of it, and they, knowing the evidence, said there's not enough evidence for us to make a formal recommendation. So it's sort of in the wings at OTAC, they're waiting for more evidence. THETA has done a rapid review on the subject, purely looking at the effectiveness, not at all looking at any of the economic data. The NICE has a sort of boilerplate, inconclusive, case-by-case, research-only recommendation. I have submitted it for publication. It's been sent back with a request for revisions. That's the state of the research is from my perspective. I think really and there's an RCT that is about to be released soon, comparing BB ECMO to mechanical ventilation. So we'll see what those results show. But I think it does inform actually that in young patients it's a decent thing to try. And then I think the other clinical take-home message is in older patients, patients who are frail, patients who you really don't think they're going to have a lifetime to accrue qualities to offset those costs, maybe not the right patient to put on the circuit. But again, that's an economic application at the bedside. That's not a clinical application. But there's no real, Eddie can speak to this, there's no real funded ECMO program for ARDS in the province. It's sort of funded through a back door. So there is no recommendation at the provincial level.
Okay.
There isn't.
So it's not a guideline, it's something.
It's kind of like on a research basis.
Okay. My second point was around your LVAD. So HQO report came what year, sorry?
2016.
Okay, so it's more recent because Ines had their report. It was a bit earlier, a few years earlier, and they actually didn't recommend the use. So Ines is equivalent to HQO for Quebec.
But they have some help.
But interestingly enough, Quebec is the first province in Canada to be putting DPVADs in. So they didn't actually listen.
Yeah.
Kelly, so next time I have a philosophical question. Comparing the UK versus here, like you showed some data, and anecdotally, we know that there's a much harder sort of line drawn there about we don't put people on dialysis if you're over 60 or whatever the number is. We say 13,000 is the limit we're going to pay. Period. But that's in a setting where there's public healthcare, but there's also private healthcare. And in a country where private healthcare is illegal, I would wonder about the rationale
2 years ago
for saying, as a patient, I want, but how can you tell me at a societal level it's not good for society and then at the same time take away my option to go around that?
I completely agree with you. I think the only way that it is societally acceptable for there to be an explicit threshold is that there is an option for private. Yep, I completely agree with you. I think it's the only way they get away with it because patients can still access it in other ways. Yeah. Right.
So this is a great example of why clinicians should be involved in doing cost-effectiveness analysis. I think we need more people like you who are actively and passionately involved in this area. So very nice talk. One or two questions. So you were actually quite specific about your policy recommendations around ECMO, and I didn't really actually see any analytic support for most of your recommendations. Like you came up with a sort of a summary cost-effectiveness threshold, and then when you were recommending what to do, you said, well, it's actually only in the young, and it's really only the people who are like the best off. And I was wondering if this is like driven by your sort of clinical judgment, or whether this is something that came actually explicitly out of the modeling. And I'm suspecting it's like really more likely the former, which isn't wrong. It's just that if you have that sort of clinical intuition, it'd be nice to see the model sort of spitting that out as well. The last comment is around bringing this kind of opportunity cost perspective into clinical decision making, because I think it's a good recommendation overall, but in practice, I have found that, for example, when I'm trying to discharge a patient from our floor, and I speak to the family and I say, well, you know, there's all these patients waiting in the emerge, families do not find this a compelling argument at all. And, you know, to try to bring the opportunity cost argument into discussions around an individual patient is just asking for trouble and potentially litigation.
And I don't think it's, let me reframe that. I don't think it's something that should be involved in our conversations with families.
Yeah.
Because I agree with you. They're really appropriately so should only be concerned about themselves. But that is the voice of the public, right? And
well, so it's a question of whether we should be actually bringing and the extent to which we should be bringing that perspective into clinical decision making. I mean, I agree it's not straightforward, and we do make resource allocation decisions all the time. We decide who goes into the ICU and who doesn't. That's a resource allocation decision. So it's not as if we don't make those decisions, but it's tricky balancing those kind of. Anyway, I think it's very difficult to bring that opportunity cost perspective explicitly into decision making.
It's much easier to make those decisions at a policy level. We've got policy that we don't put people over 70 on it. Well,
yeah.
Sorry,
yeah.
I'd like to put you on, but I can't. You know, versus trying to make that.
But you can't make those. And I think, for instance, I didn't have time to go into this, but I wanted to delve into the issue of the liver transplant story, right? Like there is an explicit criteria. You have to have not been using alcohol for 6 months. That is now being challenged.
Yeah.
And I sure hope they've got evidence to back that up, because if they don't, then the floodgates are going to open, right? So
that's why it's changing, because there is no data that says 6 months is the right amount.
So these limiting criteria, if they're based on evidence, which is why obviously you know this, why there should be more, we need to be doing more of this sort of collecting this data so that we can have this evidence to inform these limit criteria, because then it's a really easy, as you said, it's a policy decision. I'm sorry, it just doesn't meet the threshold for us.
Right, we should let people go.
Can I ask one, just as a non-qualitative person, or sorry, non-epi person here, what was your sample size like? How many patients did you use in that cycle of?
So you can use one, you can use 1,000.
So how many did you use?
0.
It's a model.
It's a model.
Oh, it's a model.
It's a model.
Okay, yeah, that tells you how naive I am.
Yeah.
Okay.
Model.
Interesting. Okay.
And you model, you put in probability for things to happen.
I think I'll stick to my mind. I can count them.